Continuing to look at historical descriptions from osteopathic authors and display the technical applications that they describe, we're looking at two descriptions from Dain Tasker, one being for dorsal or thoracodorsal rotation, or sorry, thoracolumbar or dorsal lumbar. I think dorsal lumbar is the term used. So you would have seen the slides for both of these previous. Go back and pause to read if you didn't. But the rotation essentially is keeping the shoulders still and moving the pelvis. So what I will say is that this method will take a fair amount of effort out of a practitioner, and also you're unlikely to get as much rotation as the patient is able to create or generate. And then Tasker also notes that all of the joints that can rotate, especially in the lower thoracic region or the lower dorsal region, will rotate. Those ones that are not able to move, quote unquote, in the ideal way, this will be preparatory soft tissue work because of the rotation. But he's basically saying keep the shoulder still and hold on to the posterior aspect of the iliac crest and create the rotation, which basically looks like I pin his shoulders, reach under, and then I lean and twist them as far as I can twist them. Now here's a problem. He can probably go a lot farther than this as far as rotation is concerned, but I can only lean back so far, so there may be a challenge for me. So I may limit this method because of my size and my ability to lean. Another way to essentially generate the same thing with less effort on the practitioner is to use a different lever. And you can pin the shoulders and do this, right? You have to be careful. Sometimes this is actually hard on patients' knees under certain circumstances. You can change the lever, have slightly better contact here. Right, sometimes you are able to hold on the ankle, depending on the size of the leg. Other times you're not, but I've got better contact, better control, and he goes way farther than the method that Tasker was suggesting because of me. So because of me and my size in relation to the patient and my ability to lean back, to get him to rotate as far as he's capable of, I actually need a much longer lever. I don't have long enough arms, I'm not tall enough to create the same amount of rotation as I got with the last lever as I was with the first. So that's a rotational method. Note that you don't have palpation in the area, so it is a very broad method. You don't know, or you can't target it as well. If you are targeting it in any way or you're understanding what's going on, it's the sense that you're going to get as far as tension or bind off of the lever, so either off of the iliac crest or the leg, as well as using your eyes. So when you look at these old historical osteopathic methods, you notice there's a lot of times when they don't actually palpate the things that they're trying to move. They just create very large movements, and without any other sense, they're probably using their eyes and the sense, the blunt sense off of the area that's in contact to figure out what's going on, but they don't. There's a lot of historical osteopathic methods where they're not palpating it. Now, this is a slightly different one insofar as the method will allow for palpation. So we saw one of the previous authors that we've discussed using a flexion bias position to create extension, right? So we're going to see the same thing again, but also create flexion. Now in Tasker's case, the hand that goes under the back, he doesn't talk about doing anything in particular with it. He just does talk about it going under the back, being used as a fulcrum. So he doesn't tell you to make a fist. He doesn't tell you to turn your hand in either direction. So because we don't know that, we're going to say that based on the description of the method, you probably just have a flat hand under the lumbar column. All right, so both knees are bent. The practitioner hugs around. Now this becomes somewhat cumbersome depending on the size of the patient's legs and the practitioner again. So what you see is a hug like this, kind of wrapping around. You can go underneath, but essentially what's happening is you're going to create either flexion by walk. So you stand up and then you walk up to create the flexion that you want. If you do not want flexion, if you want extension, your hand's in the same place and you simply lean, or at least in Tasker's view, you lean or put pressure into the knees. Because essentially what happens is the hand under the back, under the lumbar region, is your fixed point or your fulcrum, and the pressure from the knees goes through the pelvis and then moves the pelvis backwards in relation to where the fixed point is. The efficacy of it is questionable, right? But that's what they're going to show, or that's what Tasker described. So we have long levers And short levers again, the short lever can push up while the long lever pushes down. For flexion alone, if you push across and then hook under, for flexion alone, that may be easier on some practitioners, but either way you're still lifting both legs with your arms, so you're in quite a hunched position. So those are the two methods that we're showing with respect to what Tasker said in the lumbar region, both for flexion, just bring the knees up, extension, knees up, and push the legs or push the femurs down so that the pelvis moves backwards in relation to the lumbar column, and then the pull on the pelvis while the shoulders are still for rotation.